Hi, my name's Evelyn. This is the obesity difficult airway video. The first thing I'm going to do is think about my patient and think about the procedure and then go and check my room. So I need to go do a machine check. First thing I'm going to do is make sure I have an ambu bag, and then I'm going to check my tank pressure. So my nitrogen should be above 745. My tank oxygen should be above 1,000, and I should replace them if they're lower than that. And my pipe pressure should be around 50 psi. And then I can check my gases, so I can fill them up if they need to be filled, screw the cap tight on, and then check my interlock system. And then I can do my low pressure system leak check, and that'll pass. And then I can turn on my machine, and then check my flow meters, and then check my link 25, and make sure those are all passing. And I'll check my scavenging system, my CO2 absorbent, and then also my O2 analyzer, and make sure that's calibrated to room air and then 100% oxygen. Make sure all my monitors and alarms are calibrated correctly. And then I'll do a high pressure system leak test. So I'll just close my APL valve all the way, and then I will occlude this, and there's usually a knob here, so I'll occlude that, or you can see them on it. No, O2 flush until the system reads 30 centimeters of water, and then if the needle moves at all, then it has failed. So it should stay in the same place, meaning if there's no leaks. And then I can check my my mechanical ventilation and my bag ventilation on this machine, and then those should be functional and working, and then that will be everything on my machine check. So then to prep my room, I just need, since we're doing an elective laparoscopic cholecystectomy on a 55-year-old male, he's pretty obese just on the chart. So he's 123 kilograms, he's an ASA of 3, and he has a BMI of 40, and he's only 5'9". So just based off that, I'm anticipating a difficult intubation. So some IV drugs that I'm gonna need is midazolam for pre-op, 3 milligrams before we wheel him back for surgery. Shake the edge off, and then fentanyl 50 to 100 micrograms, and we're going to do 100 mics for him. Lidocaine 1 to 1.5 milligrams per kilogram, and we're going to do 150 milligrams for him. Propofol, we're going to do 200 milligrams. Rocuronium, we're going to do 100 milligrams, and then SIBO, we're going to do between 2 and 5%, depending on how he acts with that during the case. And then Sigamidex between 2 and 4 milligrams per kilogram, so 250 milligrams about for this guy. So then some of my emergencies, apple drugs, I'm going to need atropine, 0.5 milligrams, and then succinylcholine, 150 milligrams for that, and then epinephrine, I'm going to need 1 mic per kilogram, and then phenylephrine, 0.5 to 2 micrograms per kilogram, and then ephedrine, 5 to 10 milligrams IV bolus for a max of 25 milligrams. So then my blades, I'm going to have a MAC 3 or 4 in case he has a really big tongue or an arduous path for my AT tube, or a Miller 2 or 3 for visualizing the epiglottis. And since he is obese, I'll probably start with a Miller. And then I'll also have a bunch of emergency airway items. So I'll have Glidescope, McGrath, and I'll probably be starting my first intubation with the McGrath because that is easier than just a direct laryngoscopy. I'll have a fiber optic scope, I'll have a difficult airway cart nearby, a couple LMAs, some oral airways, and then my Crite kit if worse goes to worse, and then some bougies. And then some ETTs. I'll have an 8.0 predicting, but I'll have about a half size up and half size down. I'll have my stylet, my lube, and then I'll anticipate to secure the tube around 22 to 24 centimeters at the lip. And then I'll just have some positioning equipment, so egg crate foams, OG tube just in case, a suction. He's overweight, so he likely has a GERD too. So anyway, once I have all those things, I can go back and identify my patient. So he is 123 kilograms, ideal body weight for him is 72 kilograms, so he's quite a bit a ways away from that. So I'll go in and I'll review some medical history, medications, if he has malignant hypothermia, or if he knows what that is, if he has that in his family, allergies, if he's NPO, and then, hey, do you have any blood pressure issues? And he'll just say, yeah, I have hypertension, diabetes type 2, obstructive sleep apnea, obesity. So do you sleep with CPAP at night, or do you use a CPAP? And yes, he does. I'll ask him if he's had any labs or any EKG issues in the past, or if he's been hospitalized for any cardiac issues. So then my physical assessment, just upon seeing him, I can see that he has a really thick, pudgy neck, and he has a pretty big head. And then he also has the beginnings of a goatee and a beard. So I'll listen to his heart and lungs, and then just confirm what he's kind of told me, and then ask if he smokes as well. And then with his goatee, I'll ask him if he would consider shaving it or trimming it at all for the surgery. So then my other questions is that would be, can you open your mouth? Can you copy me? open your mouth, and then I'll look at his teeth, and then I'll see that he has a melancholy score of 3. His incisor gap is above 3 centimeters, so that's at least good for him. Can you stick your tongue out, sir? Can you bite your upper lip with your lower teeth, kind of like a Shih Tzu? And then can you touch your chin to your neck, and then look up with the ceiling, at the ceiling? And then I don't need to measure his neck because I can see that it's very thick. So, and he has a pretty short neck also. Can you thrust your jaw out, kind of the same as a Shih Tzu, but reach your jaw as far out as it goes? He also kind of has a receding chin. And then he also reports that his wife says that he snores at night. So after I've done that, I can kind of talk about the procedure risks and benefits with him after I've done my thorough pre-op evaluation. So this procedure is minimally invasive. We're just going to be doing some trocars to do the surgery instead of opening you up and doing a big incision. But we just have some small pokies that go through your stomach, and then it grants us access to your organs that we need to get a hold of. And then there's a camera that lets us see inside, and we're just going to remove your gallbladder with those little instruments poked through your skin. And then we're just going to put an ET tube down through your throat to help us breathe, because we will need to paralyze you to have the best outcomes for the surgeon. And then some risks for the surgery is that you could have an increased risk for DVTs or pulmonary embolisms. And also, because you're a little bit more overweight, it might take a while for the anesthetic to wear off. So it might take a little bit longer for you to feel 100% back to normal again. And then you might have some cardiac abnormalities, which increases the strain on your heart in addition to your pre-surgery state, because you have more tissue for your blood to pump through. And then you'll have potentially a harder intubation for me. So best case scenario, I'll be able to just stick the tube down your throat. But worst case scenario, you might have a little scar or a little incision on your throat because it was really hard for us to get the tube in, so just FYI. And then if it's the worst case scenario, you might have to stay in the ICU just slightly because we had to re-intubate you, or some trauma or some issues happened with your airway, but that's so a small outcome that could happen. Some benefits is securement of the airway, in your case is critical because you need to be paralyzed, like I said. And then it also, with the muscle paralysis, helps ensure the surgeon has the most accurate surgery that he can. So then some indications is that you need, like I said, complete muscle paralysis because of the surgeon, and then also because CO2, when they're gonna poke those things in your stomach, and then they need to blow up your stomach a little bit and put some air in it so that they'll be able to see. So that can irritate your diaphragm, and that also is a reason that we're gonna be needing to paralyze you. So alternatives to this, we're just a small surgery center, so there's some other centers that they can do just like a spinal, and you won't have to be as paralyzed, and it won't be as extensive. But for this facility, we won't be able to do that here. So consent plan, once I've gone over those things, then I'll have him sign that. Then we'll give him his midazolam, and then he'll wheel him back. Answer any questions before we give him midazolam, obviously. But so now we'll ask him to scoot over to the blanket. Now we're in the cold OR. We'll just put a warm blanket over him. After he scoots over to the bed, and we'll put on the pulse ox, the blood pressure, the EKG stickers on, and then I'll just explain that this is ramping because you're a potentially difficult airway. I just need to give myself the best chance that there is to intubate you the first try, the least painful way possible for both of us. And then once he's all situated and calm, he'll say, hey, this is a mask of just pure oxygen. I just need you to breathe really deeply, and this is just oxygen. I'll tell you if there's any funny gas going in there or anything. But I'm just going to denitrogenate you and pre-oxygenate you at 6 to 8 liters per minute for a total of 3 to 5 minutes. So keep taking some deep breaths. I might need to use 2 hands. I might need to tegaderm his beard if you didn't consider shaving it, or put gel around my mask so that it will have a seal so there's no leaks. I need to listen for leaks, and then once it's been 35 minutes, then I can look at my monitors and make sure everything looks good, and then I can start my IV induction. So once he's breathed and he's all relaxed, then I can start pushing my meds. So I'll push my fentanyl, I'll wait 2 to 3 minutes, and then I'll use my lidocaine 1 to 2 minutes, and then I'll use my propofol and intubate once they're in stage 3, so I can check my lid reflexes. I can open his eyes and see where those are at, and then once those are in and I feel happy, then I can start my intubation. So I'll just take my McGrath straight away and my 8 tube with Silette and lube on it, and then I will just optimize his positioning also before, and and then align his airways, use a jaw thrust if I need, but I'll just go ahead and see what we can see. All right, and I have a pretty decent view. Trying not to rock on his teeth and just lift up his head. I can see it on this monitor that it's going through the cords, and now I'll ask my circulator to pull the stylet, and then I'll put it the rest of the way through the cords. And then I can take my graph out, and that was a pretty painless intubation on this guy that I thought might have been difficult. And I didn't even have to use an oral airway or anything. So now I can hook up my circuit, and then I can watch for ETCO2, and then I can watch for chest rise, and then also listen in addition for chest rise. And then once I feel like it's in a good spot, and the tube is misting, then I can inflate the cuff and then secure it to his face. So now this is taped or tied. And now I can use my rocuronium once his airway is secured, wait for paralysis, and then I can turn on my SIBO at 2 to 3%, and then reduce my oxygen to 2 liters per minute because we are using the SIBO. And then now I'm assessing for further loss of consciousness or if he's starting to wake up, and just make sure he's still in stage 3 and the surgery can start. Now I can tape his eyes, we can double check that everything went well and that he's ventilating still and everything worked, there's no issues. So now the procedure happens, and now the patient is ready to be positioned. So the circulator is going to come. He's supine, he might be left tilted, he might be in reverse Trendelenburg, just to whatever view the surgeon wants he's going to be. And if the surgeon's okay with him being ramped, then we're going to leave these here, but if not, we can adjust these as needed. So then I'll pad my pressure points, so my elbows, my heels, his head sometimes. I'll make sure that he had a pup on his butt before this, and then so then with the procedure we'll go through. And now for the end of the case, they're wrapping up, so I can use my Sigamadex, because he still has, not all 4 twitches are back, so I'll use my Sigamadex, and then we're going to do an awake extubation, because we don't want its airway obstructed, or him to be hypoventilating, or us to just have issues with him waking up and going into further emergency issues. So the surgeon said that these were okay, so he's waking up in the same exact position, and I'm just going to wait till he kind of progresses up to awake. And he looks like he has airway reflexes. He might be starting to bite his tube, he might be starting to cry. He'll be able to follow commands, he'll be able to give me thumbs up, he'll have good tidal volumes and good numbers on my machine, and I'll be able to see him moving air with my CO2. And then I'll ask him to lift up his head, and that'll pretty much be like the final thing for me, and if he can give me thumbs up and he's like following commands. So once I have all those things and I'm confident he's gonna wake up awake, we can pull the tube out. So I'll deflate my cuff, pull the tube, I'll put some nasal cannula on him with 6 liters per minute going, so that he's safe and good, and I'll just transport him completely sitting up to PACU to promote adequate ventilation. And then with my PACU nurse, I'll just tell her everything that happened with the surgery. So I'll say this is a 123 kilogram male, he underwent a lap chole, he was a difficult airway, but we got it with the McGrath, and it wasn't too bad, but it is pretty bad with just a DL. And then he had 3 milligrams of Versed going back, and then he had Sigamadex for reversal, and he was completely reversed before we came back here. He also got dexamethasone and dexmedetomidine. He was shivering a little bit, and he's not in any pain, he's comfortable at this time. Let me know if you have any questions, and continue monitoring him.